Hi, this is Dr. Reynaldo ROJoson, Director of the ROJoson PEP Talk. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the PEP Talk. I completed the core course on October 9, 2021. From October 23, 2021 onwards, I have been tackling health disorder and health issue courses. This may take 3 years or longer. My pep talk today is entitled Fundamentals and Generalities in Medical Management of Thyroid Cancer, Part 1. This is part of the cancer course. The empowerment objective is for the lay people to have an understanding of the fundamentals and generalities in the medical management of thyroid cancer. Some definition of terms in the title and the limitation of coverage of my talk. Fundamentals to mean simplest and essential facts and theories which can serve as a basis or foundation and support for advanced information. Generalities to mean general statement of information, not covering specifics and details. Medical management to mean diagnosis and treatment of thyroid cancer by physicians. For part one, the contents will be the following: screening for thyroid cancer, symptoms that will lead to suspected presence of thyroid cancer, clinical diagnosis of thyroid cancer, paraclinical diagnostic procedures for thyroid cancer. Part 2 will be tackled next week. Let's start with screening for thyroid cancer. Screening for thyroid cancer means looking for a thyroid cancer that may be present in apparently healthy and asymptomatic persons, both females and males. The general screening methods consist of the following: risk assessment interview or evaluation. Number 2, risk assessment interview and physical examination. Number 3, risk assessment interview and physical examination with the use of instrumental or laboratory diagnostic procedures. Let's start with the first general screening method, risk assessment interview or evaluation. This is essentially looking for higher risk for thyroid cancer in a particular patient or person, such as presence or absence of family history of thyroid cancer, presence or absence of history of radiation exposure, especially during childhood, and history of excessive exposure to some chemicals. If positive for higher risk, proceed to symptom sign evaluation or physical examination, and if indicated, do instrumental or laboratory diagnostic procedures. If negative for higher risk, may stop here, or better still, proceed to symptom sign evaluation, which means interview and physical examination to complete the basic essentials of screening. For risk assessment interview and physical examination, this constitute the basic essentials of screening. If positive for higher risk and suspected presence of cancers based on the symptoms and sign, proceed to instrumental or laboratory diagnostic procedures as indicated. For the risk assessment interview and physical examination with the use of instrumental or laboratory diagnostic procedures, do instrumental or laboratory diagnostic procedures only if positive for higher risk for cancer and or if with suspected presence of cancer based on symptoms and signs. The caveat here is, in this era of commercialism in medicine and healthcare, beware of a lot of hospitals and laboratory clinics peddling screening packages for cancer. Don't be swayed or easily by the marketing and discount offers. In the Philippines, currently, there is no official nationwide thyroid cancer screening program. For my personal recommendations, I would recommend neck and thyroid self-examination monthly starting at age 18 and onwards, or adult onset, and then if a mass is felt, consult a physician right away. This shows how to do a self-examination of the thyroid as part of the screening for thyroid cancer. So you stand in front of a mirror, okay, and then prepare a glass of water, then drink it. Okay, upon swallowing, look at your neck through the mirror and see if there's any unusual bars on the neck. Then after that, palpation. Okay, hug your windpipe with your thumb and 2 or 3 fingers on the other side, and then as you swallow, look for palpate for a enlargement or a nodule or a lump on the thyroid gland. So this shows this illustrates an enlargement of the thyroid gland. The original size is this one, but now it's enlarged, almost symmetrically enlarged. And then this one shows the presence of a single or solitary thyroid nodule on the neck. And then this one shows multiple nodules. These are the things that one will look for during palpation. Symptoms that will lead to suspected presence of thyroid cancer. The alert symptoms or symptom cues are the following: a lump on the central part of the neck, a lump on the side of the neck, a lump on the neck with persistent hoarseness of voice. I will expound on this in the section in clinical diagnosis of thyroid cancer. The clinical diagnosis of thyroid cancer, or a clinical diagnosis, just means a conclusion or decision made by a physician after examining a patient and after evaluation of the data on symptoms and signs. Symptoms are what are felt and observed by the patient or a person on his or her body. Signs are findings of a physician after a physical examination of a patient. Procedures in the clinical diagnosis of cancer or thyroid cancer, starting with the patient presenting with symptoms, and then the physician evaluates the symptoms to see if these are alert signals or symptom cues for cancer or not. Then he or she does the physical examination to look for sign cues for cancer, and then processes symptoms and signs to determine whether a cancer is present or not. Okay, so this is the clinical diagnosis. Whether not cancer, cancer, if it's cancer, whether it's suspect, probable, or most probable. The processes used in the clinical diagnosis of cancer consist of 2: pattern recognition and prevalence. Pattern recognition process means realization that the patient's presentation conforms to a previously learned picture or pattern of a disease, whereas prevalence process means the choice of a diagnosis is based on the frequency of occurrence of the disease in a certain locality, in a certain age and sex group, and in the affected organ and system. So remember the definition and behavior of thyroid cancer when one is looking for the pattern recognition in the alert symptoms or sign cues. Remember this definition of thyroid cancer. It's a medical disease when some of the thyroid cells grow uncontrollably with a potential to invade adjacent body tissues and organs. So look for signs of invasion, and it can also spread to distant tissues or organs. So look for cues for distant spread. Again, the alert symptoms or symptom cues for thyroid cancer: lump on the central part of the neck, a lump on the side of the neck, a lump on the neck with persistent hoarseness of voice. So showing a normal thyroid gland, and then there's a solitary nodule that was palpated or that is present. So right away, this is already a cue for a possible thyroid cancer. Then in the presence of multiple nodules, this is also a cue for possible thyroid cancer, but this has to be evaluated further. So suspect thyroid cancer if the lump or lumps are hard inconsistency, number 1. Number 2, fixed, okay, not mobile. 3, accompanied by a persistent and progressive hoarseness, which could be a sign of invasion. A lump on the side of the neck, which could be a lymph node and which could be a sign of spread. And another sign of possible of a spread will be a distant mass outside the neck, suggestive of a spread. Usually, the most common sites of metastases for thyroid cancers are the bones and the lungs. The absence of cues for malignancy, more likely the lumps are benign or not cancer. Okay, this is more common than thyroid cancer. The more common types of thyroid cancer in the Philippines, there are 4: papillary, follicular, and aplastic medullary. The most common still, with 90% incidence, will be papillary, next follicular, then anaplastic. The least common is medullary carcinoma. So behavior of common types of thyroid cancer. Papillary thyroid cancer usually spread via the lymph channels or lymph nodes. Follicular thyroid cancers usually spread via the blood channels or bloodstream. And then the most common sites of metastasis are the bones and the lungs. So this illustrates a patient with a solitary thyroid nodule. Okay. This could, just by looking, there's a nodule. It could either be benign or malignant, and the most common benign nodule is a colloid adenomatous nodule, and the most common cancer is your papillary carcinoma. If the nodule is hard, like this one, it feels hard, then papillary thyroid carcinoma should be suspected. So this patient shows a solitary thyroid nodule, which, if there are no cues for malignancy, this is a solitary colloid adenomatous nodule. This patient shows multiple nodules, and if there are no cues for malignancies, then this is what is called multiple colloid adenomatous goiter. It's a benign condition. The patient with a lateral neck mass, okay, which is deemed to be the lymph node, and then if this is associated with a thyroid mass here on the center, then one should suspect papillary thyroid carcinoma. Another patient with infiltration or invasion of the skin over the thyroid mass. Okay. Another patient showing the same thing. So in these two patients, we have to suspect papillary thyroid carcinoma. A patient with a thyroid mass and a distant mass, we suspect follicular thyroid carcinoma. Another patient, usually elderly patient with rapid growth of the thyroid mass, okay, leading to compression, leading to the need to insert a endotracheal tube to facilitate breathing, and then the need to insert a nasogastric tube to facilitate feeding. Okay, and this in such a patient, we have to suspect anaplastic thyroid carcinoma. In this particular patient, this mass is soft, but it's big and it's compressing the other side. So on aspiration, what was gotten was our colloid fluid, and then the mass significantly decreased in size. So this is what is called a colloid adenomatous nodule. It's benign. Again, procedures in the clinical diagnosis of cancer. Patients presenting with symptoms. Physician evaluates the symptoms to see if these are alert signals or symptom cues for cancer or not. Does physical examination to look for sign cues for cancer, processes symptoms and signs to determine whether cancer is present or not, or clinical diagnosis. So the possible conclusions could be not cancer, cancer suspect, cancer probable, cancer most probable. So the next thing for the physicians to do or to decide is whether to do a paraclinical diagnostic procedure or not, or the so-called instrumental or laboratory diagnostic procedure. So let's now go to the last topic, paraclinical diagnostic procedure for thyroid cancer. The foremost indication for a paraclinical diagnostic procedure can be stated this way. If you're not certain on the primary clinical diagnosis and you need to be certain or be more certain before treatment, then go for a paraclinical diagnostic procedure. To decide on the indication of the paraclinical diagnostic procedure, the physician uses two processes: the degree of certainty on the primary clinical diagnosis and comparison of the treatment plans for the primary and secondary clinical diagnosis. As a rule, there is no need for paraclinical diagnostic procedure if you're quite certain of your primary clinical diagnosis and the treatment plans for the primary and secondary diagnosis are the same. If there's a need for paraclinical diagnostic procedure, the physician uses the BRCA processes. B stands for benefit, R risk, then C cost, and A availability. The physician gives or lists down the various options and then gives the BRCA data. With the data given, the patient is asked what he or she prefers. Examples of a BRCA comparative analysis, options 1, 2, 3 on the first column. Then the benefit in terms of to be more definite on the diagnosis. This one has a 99% accuracy, option 1, option 2, 90%, option 3, 60%. Assuming that all the risks are acceptable, are slight and mild, and then the cost differentials are 4,000, 3,000, 1,000, and assuming that all are available. If one were to ask which one should not be chosen outright, so the option 3 should not be chosen because it has the lowest benefit, okay, only 60%, even though if the price is only 1,000. The best still your option 1 with 99%. If the patient cannot afford 4,000, then you can go for option 2 if she can afford 3,000 because accuracy is still 90%, which is still good enough. There are several issues to discuss in the selection of paraclinical diagnostic procedure to be done for suspected cancer. There are a lot of confusions, not to say errors happening. Number 1, not recommended. Using the FAD, the popular ones without comparative analysis, benefit, risk, cost, and availability of the other options, usually with no considerations of the cost effectiveness and patient preference. Number 2, also not recommended, shotgun approach, ordering every possible test just to catch a diagnosis, shotgun, and ordering tests not needed for the diagnosis of cancer. The example of shotgun approach would be ordering ultrasound of the thyroid gland or the neck, thyroid functions, FT4T3, and TSH, and thyroid scan all at the same time. Okay. So what is commonly practiced in the country, in the community, is the shotgun approach using these two, ultrasound and thyroid scan, because this is not as popular as before. Okay. So the recommended approach will be targeted and sequential with prioritization approach. If there's a thyroid lump, if there's a need for a paraclinical diagnostic procedure, one can go for an ultrasound first, then after the ultrasound, then if indicated, do a needle biopsy. And if still indicated, you can do the thyroid scan as the last resort. Okay. If hyperthyroidism and hypothyroidism is being suspected, then that's the time you can do the thyroid function test like FT4, FT3, TSH. Example of a thyroid ultrasound on the neck. An example of a needle aspiration with or without biopsy as a paraclinical diagnostic procedure. Okay, so if the mass is solid, samples will be gotten for microscopic examination. This is what we call biopsy. If not, okay, the fluid is just, if there is fluid, it's just aspirated. I'll just show you how a needle aspiration of a colloid cyst is being done. It's a simple procedure done in the clinic, usually with the patient sitting down. At times, patients can lie down during the procedure. So you can see a fluid, colloid fluid is being sucked out. Okay. So this is an illustration of a needle aspiration of a colloid cyst. After the fluid has been sucked out, the mass can either completely disappear or tremendously decrease in size. Thyroid scan, a picture of a thyroid scan, which can show either hot nodule or cold nodule. Okay. Example of BRCA comparative analysis in a patient with a dominant thyroid mass. Okay. So just using these three, ultrasound, thyroid scan, and CT scan. Okay. Comparative benefit. All of these are imaging techniques. That's why it's indirect compared to biopsy, which is a direct technique of getting a sample. Okay. Ultrasound, let's say 2+ advantage. Thyroid scan 1+, and then CT scan 3+. Okay. Risk, no pain, but with radiation, and then no pain with radiation for CT scan. The cost is most expensive is CT scan. Okay, assuming that all are available. So usually, the most cost effective here at this point is your ultrasound, and this is commonly done. Okay, rather than CT scan and thyroid scan. Another example, now including including the biopsy now. Okay, so this is a direct sampling of the tumor of the mass. Okay, so it gives you the best diagnostic yield compared to the other three. Okay, but the only problem is that there's a little pain on the needle prick, and then here are the comparative prices. So if you were asked which one's the most cost-effective diagnostic procedure, okay, removing the pain factor, then you can say that biopsy is still the best. So takeaway or summary, I just finished with the part 1 for today. Part 2 will be tackled next week. So part 1, content screening for thyroid cancer, screening that will lead to suspected presence of thyroid cancer, clinical diagnosis of thyroid cancer, paraclinical diagnostic procedures for thyroid cancer. The takeaway in relation to patient empowerment, be always in touch with reliable medical information on fundamentals and generalities in medical management of thyroid cancer. Knowledge is power. It gives power. Use the 4 Ks of patient empowerment: kaalaman, kakayanan, karapatan, and kapangyarihan to gain greater control over decisions in the medical management. So with that, I end my pep talk. Generalities, fundamentals, and generalities in the medical management of thyroid cancer, part 1. I hope I have empowered you to have a better understanding of the generalities and fundamentals in the medical management of thyroid cancer. With that, I say thank you. Thank you for your kind attention. Mabuhay kayong lahat.